I'm Michael Lanuti. I'm one of the thoracic surgeons at Massachusetts General Hospital in Boston, Massachusetts. I'm in a rather large division of thoracic surgeons, and I'm the director of thoracic oncology for our division. I have clinical interest in lung cancer, esophageal cancer, mesothelioma, and I also have a translational lab that looks at novel treatments of lung cancer. What extent of lung resection is necessary for stage 1 through 3 non-small cell lung cancer? And the surgical resections include wedge, segment, lobectomy, and pneumonectomy. In general, the extent of lung resection for lung cancer is based on multiple factors: clinical stage, tumor size, the location of the tumor in the lung, that is in the outer zone, middle zone, or central zone, which I'll refer to a figure, and ultimately the patient's performance status or cardiopulmonary reserve. Assuming a patient has good lung function, wedge resection for a solid invasive lung cancer is considered inadequate. That is, there's a higher recurrence rate compared to segmentectomy or lobectomy for solid invasive tumors. In contrast, subsolid tumors, otherwise known as ground glass opacities, with a minimally invasive component or an in situ component, a wedge resection has been deemed a safe option for those patients, where studies show 100% 5-year survival with wedge resection. You know, our data dates back to 1995 that was randomized, where lobectomy was determined to be the standard of care for stage 1 lung cancer. However, there are newer randomized studies that are looking at tumors that are less than 2 centimeters, where segmentectomy appears to have an equivalent outcome regarding survival compared to lobectomy. So lobectomy is still the standard of care for tumors that are 3 centimeters or greater. It's still the standard of care for tumors that are in the middle or central zone, where segmentectomies are often reserved for tumors that are under 2 centimeters, where there's no evidence of N2 or mediastinal nodal disease. You know, in stage 2 and 3 tumors, where there can be N1 or N2 disease, most surgeons are still advocating for lobectomy as the best chance for cure, as long as the patient has enough pulmonary reserve. And lastly, pneumonectomy is reserved for the central zone of invasive tumors where lung-sparing techniques cannot be achieved. And the lung-sparing techniques are sleeve lobectomy, or sometimes what we call pulmonary artery sleeves, ways to reconstruct and preserve lung. Eligibility, again, is always based on lung reserve and performance status and good heart function. But pneumonectomy can be considered for any one of those stages, stage 1, 2, or 3.